Thank you, Mujahid. Assalamu alaikum, dear colleagues, and I'm very much thankful for the organizer, especially Dr. Suhail Akhtar. So he's my teacher as well. So, and for inviting me for this talk, and I'm really honored to be here among all of you, especially all three respected my teachers and seniors, Professor Musawir Saab and Dr. Arslan and Dr. Salimullah. So I will try to give some updates on COPD in the next 20 minutes likely. So recently गोल्ड की गाइडलाइन पब्लिश हुई एंड there are numerous amount of literature is coming up for different aspect of COPD. So basically COPD is a heterogeneous disease hai, and so it's so बहुत सारी चेंजेस आई हैं और सो विल ट्राई कि हम उसको क्विकली रिव्यू कर लें क्या चेंजेस हैं एंड क्योंकि इस दफ़ा गोल्ड ने बहुत ज़्यादा चेंजेस किए हैं कंसिडरिंग लास्ट 1 year लिटरेचर सो फ्रॉम डेफिनेशन टिल in fact treatment, so everything has changed. So we'll try to capture the what's new in diagnosis. So I don't have any financial disclosure, but I have used table and figures from the GOLD guideline. So this is my disclosure. So GOLD has changed the definition, in fact, and it's now very simple. Okay, how you define COPD? So COPD is basically defined as a heterogeneous lung condition characterized by chronic respiratory symptoms, dyspnea, cough, sputum production, and due to abnormalities of either in the airway or the alveoli. So chronic respiratory symptoms due to abnormalities either in मेरे पास भी नहीं आ रहा ना इसमें वहाँ पे भी ये सिर्फ ये स्लाइड आ रही होगी so either chronic respiratory symptom either due to abnormalities in the airways or at the level of alveoli. So if there is a problem in airways, so common problems are chronic bronchitis, bronchiolitis, and in an alveolar level, we know the most commonest abnormality is the emphysema. So there are lots of causes of these abnormalities. So that's why they make it now very simple that COPD is a very heterogeneous disease, secondary to the abnormalities either in the airways or in the alveoli that leads to obstructive nature of a disease. This is a newer definition of a COPD. So now it's simplified and it's mainly focused on the airways abnormalities as well as at the level of alveoli. So if you look at the impact, so near 5% of global death is caused by COPD, or recently you reported it's now 6%. And almost more than 300 million people worldwide is at present is suffering from COPD, and it's third leading cause of death. Estimated था कि 2030 में third leading cause होगा, but in 2019 it becomes a third leading cause of death. And there are very few literature available for Pakistan. In a one study, 6.9 million people are currently suffering from COPD. And we all know that the most important cause is the cigarette smoking. लेकिन a paradigm बहुत shift हुआ है. So it's not only the cigarette smoking, there are lots of causes of a COPD. So this is the first time when literature in fact talked about the other causes other than the smoking. Still the smoking is the leading cause, but now the focuses are some different diseases as well. So if you look at the prevalence, so the global prevalence is 10.3%, in men it's 11.8%, in women it's 8.5%, and around 3 million deaths annually. And it is estimated that the toll will goes up, and by 2060 it is estimated that the 5.4 million people will die because of this disease. So this is a summary of a whole of the literature about the prevalences. So I summarized all these things in just one slide to let you know or think about how what's the impact of this disease on healthcare. And so something about the pathophysiology and the disease process. The first time this terminology used was gatomics. So what is gatomics? So gatomics is basically an interaction between gene, environment, and lifetime. So previously, we all know that it's written that COPD is secondary to cigarette smoking, biomass fuel exposure, and in some cases of genetic disorder like alpha-1 antitrypsin deficiencies. But now it has been established that there are certain genes that are more prevalent in COPD, and the interaction of the environment doesn't mean only the smoking or a biomass fuel exposure. It also includes the host factor. So developmental abnormalities as well as increased aging process. So that's why lifetime is included. So gatomics means the interaction between gene, environmental factor, host factor during the lifetime, because we saw lots of patients, their FEV1 declines very rapidly as compared to the same phenotype of the other patients. So usually lung की जो development होती है वो from birth शुरू होती है and it matures at 20 years of age. Females में थोड़ा सा early होती है but 20-25 years of age है, and then a little plateau phase आता है and then it goes down. So FEV1 decline certain times is very rapid, certain time it's very slow, and secondly development में भी problems है. इसमें genetics role play करता है, some environmental role play करते हैं from the birth, intrauterine life से लेके development years, childhood infection, everything play a role. So that's why the use of a lifetime is included. So I'm not going into very much detail of pathophysiology, उसके लिए एक पूरी talk चाहिए, so just give you a flavor of what is gatomics and how the things are changing. So there are, on the basis of these new pathophysiological mechanisms, there are new proposed categories. First time इस literature में ये publish हुआ in 2021 अक्टूबर के अंदर. इसमें terms use हुई early COPD, mild COPD, pre-COPD, young COPD. So let's see what does it means. So early COPD, we know early का मतलब क्या होता है कि is just a beginning of a process. So early, like if you look at the ischemic heart disease like atherosclerosis, बचपन से शुरू हो जाती है. It manifests late. So likewise COPD, जैसे मैंने कहा कि developmental issues भी intrauterine life से, so the process has started very early. So biological early and manifestation बहुत late होती है, तो उसको clinical early. So it's very difficult to at present differentiate the biological early कब शुरू हो रहा है, clinical early किस में होगा. That needs gene studies. We need some biomarkers so we can pick whose basic or a biological earlies goes into the clinical early COPD. So it is very early, but there are things to develop हो रही हैं to pick up these biological earlies. So for now, it is recommended to use early COPD only for a biological early. So no clinical early. So because there is no clear-cut differentiation, no biomarkers available or genetic studies available to pick these clinical early things. Mild COPD is based on the airway obstruction. So mild COPD doesn't mean कि early COPD में ये mild COPD हो जाएगी. So it's related to airway obstruction severity. So अगर airflow obstruction is mild है for any age, for any phenotype of a patient, so उसको हम mild COPD कहेंगे and should not be confused with early COPD. Early COPD is a biological changes in a person who may or may not develop a COPD in their lifetime. Young COPD. So any patient, previously क्या था कि Mr. COPD उसको कहते थे elderly patient, smoker, and typical appearance of a pink puffer or a blue blotter. So young COPD So any patient who develops COPD before the age of 50 years is a young COPD. Young COPD में it doesn't mean कि severity mild होगी. Patient may present with a severe disease, patient may present with a milder disease. So this young COPD is associated with significant structural and functional lung abnormalities that can have a substantial impact on the health. कौन लोग होते हैं जिनमें यंग सीओपीडी डेवलप होता है अदर देन smokers and environmental factor? So those patients who develop basically respiratory diseases early in their lives, like hospitalization due to different infections, TB, early period of life, they develop a COPD in a relatively young age. And definitely there are gene predisposition, like we all know that alpha-1 antitrypsin deficiency is associated with a younger patient with a COPD. So genetic predisposition है, early childhood infection है, developmental problems है, वो trajectory पूरी develop हुई है, but I'm not going to discuss that trajectory because this needs a lots of time. Pre-COPD patient clinically symptomatic है, but PFT is normal है. So it's a pre-COPD. It doesn't mean कि हर pre-COPD वाला COPD develop करेगा, but these are the symptomatic patients with a normal spirometry. Spirometry में अगर ratio preserved है, we know कि diagnostic criteria, all of you know that कि post bronchodilator FEV1 to FE ratio अगर less than 0.7 है, तो it fulfills the diagnosis of COPD. If not, then we cannot label this patient as a COPD by literature. So if the ratio is maintained, patient is symptomatic, although his FEV1, FEC ratio is low, so this new term is developed that's called as a PRISM, preserved ratio impaired spirometry. This patient is symptomatic, FEV1 is low, FEC is low, but the ratio is maintained. So who are these patients? They are basically current and former smokers. Total population-based studies में the prevalence is range from 7.1 to 20% of this group, and this is associated with increased all-cause mortality. So we have to address these patients और इनको close follow-ups की ज़रूरत है. But again, it's not a very stable phenotype. Patient may develop a full-blown COPD, or even throughout the life, they may remain like same without reducing their ratio. इसके clinical impact क्या है? Do we need to treat these patients of a PRISM or pre-COPD because they are symptomatic with a normal spirometry? So recently, a very good study published, a very large trial published in NEJM in just September 2022, recently on use of treatment in these tobacco-exposed persons with symptoms and preserved lung functions, and this study shows that there is no effect of a treatment on these patients. So we should try to dig out the cause in these patients and treat the cause. Simple bronchodilator is not very helpful. In this the study, Rethink study that is published in NEJM in this September, just बहुत ज़्यादा citations हुई हैं, and there are lots of discussion on this study is going on because pharma पे बहुत बड़ा जो है ना एक question mark लगता है because so we all know there are lots of causes of COPD, but we all agree that cigarette smoking is the most important cause other than the biomass fuel exposure, but there are other causes is also very important. So before this year we just used term COPD, whatever the reason. So now a taxonomy is generated और पहली दफ़ा etiotypes जो है ना COPD को differentiate किए गए etiotypes are different. So like if COPD is caused by a genetic disorder like alpha-1 antitrypsin deficiency, so it should be labeled as COPD-G. If it's abnormal, secondary to abnormal lung development, COPD-D. If secondary to smoking, COPD-C, cigarette smoking. If secondary to biomass fuel exposure, COPD-P. Due to infection, COPD-I. COPD and asthma overlap like COPD-A, and if there is a no known cause, to COPD-U. But the question is there any clinical impact of these things or not? So time will tell. But we all see that these patients behave very differently. Like biomass fuel exposure वाले patient जो है bronchodilator and steroids को उस तरह response नहीं करता जैसे smoker करते हैं. Post TB अगर किसी को obstructive airway disease हुई है तो they don't behave like a patient with a post like a ex-smoker or a former smoker like COPD. So maybe in near future or in the coming years, we see a different, because pathophysiological mechanism are very much different in all these causes. So we have to address accordingly. और इसी वजह से अब वो treatable traits आई हैं, will discuss in a treatment as well. Diagnosis में basically सबको पता है कि diagnosis के लिए ज़रूरी है spirometry less than 0.7 हो, और any patient who is symptomatic, chronic symptoms, cough, shortness of breath, wheezing. इस स्लाइड को शो करने का मकसद ये है कि how to pick early COPD. So this is a very good questionnaire that's called as a capture for primary care physicians. So अगर ये capture questionnaire use करें, scoring है 6 तक, common questions है, less than 2 है score, ज़रूरत नहीं है evaluation की, less likely COPD. 5 and 6 most likely COPD, do PFT. And between 3-4 अगर है तो इस patient को clinical judgment पे you can try to diagnose, use diagnostic tools or for additional testing for some alternate diagnosis. So it's a very good and simple tool. Capture के नाम से primary care physicians को अगर आप teach करते हैं तो you can give this tool to them to assess or pick early COPD things. Sometime additional diagnostic आपको चाहिए होती हैं, but first time role of CT scan जो है ना वो describe हुआ है, क्योंकि कभी भी COPD का CT नहीं था, तो it's now ये CT आपने कब कब कराना है. Patient recurrent infections के साथ आ रहा है, think of a bronchiectasis, do a CT scan because it will change the management. Symptoms disproportionate हैं उसकी spirometry के मुकाबले में, do a CT scan to rule out other things or see what is happening. या आपको intervention करना चाह रहे हैं, like lung volume reduction surgery है, endobronchial valve है, patient को आप देखना चाह रहे हैं heterogeneous homogeneous emphysema है, तो do a scan or a low dose CT for lung cancer screening. तो first time CT scan clear, उसके role define में COPD में. And now come to the management part. We know कि हमारे management जो है वो sorry यहाँ से जो है वो आगे नहीं बढ़ रहा फिर. So goals of treatment हमारे होते हैं reduce symptoms, reduce mortality, reduce the risk of exacerbations. So these are our goals of a treatment. So mainly rehab पे डॉक्टर साहिमा बात करेंगी, नॉन फार्माकोलॉजिकल मैनेजमेंट पे डॉक्टर सुहेल बात करेंगे, इंटरवेंशन पे डॉक्टर अली मुसानी बात करेंगे. तो आई ओनली फोकस ऑन अ फार्माकोथेरेपी के उसकी जो है ना रिसेंट चेंजेस क्या हुई हैं. तो फार्माकोलॉजिकल मैनेजमेंट का कोई बेनिफिट है या नहीं है? एंड डिक्लाइनिंग ऑन FEV1, reducing, we all know कि symptomatic improvement तो होती है, but is there a benefit in a decline of FEV1 or long term benefit के लिए? So individual trials have not been sufficiently conclusive to show a pharmacological support के rate of FEV1 decline होता है. But this is a study that was published in American Journal of Respiratory Care in 2021, the systematic review, and that included 9 studies that shows कि जिनको ब्रोंकोडायलेटर देते हैं तो ट्रीटमेंट जो फार्माकोलॉजिकल मिलता है तो 5 ml पर लीटर के हिसाब से इनकी रिडक्शन है FEV1 डिक्लाइन में एज कम्पेयर टू प्लेसिबो. ब्रोंकोडायलेटर यूज़ कर रहे हैं तो 4.9 ml पर ईयर है, एंड इफ़ यू आर यूजिंग स्टीरॉइड्स तो 7.3 ml पर ईयर के हिसाब से डिक्लाइन FEV1 का कम होता है. दिस इज़ द फर्स्ट मेटा एनालिसिस और सिस्टमैटिक रिव्यू दैट शोज impact on FEV1 decline. एक और स्टडी आई विल डिस्कस जिसमें ये डिक्लाइन शो हुआ है. सो व्हाट इज द चेंज इन COPD असेसमेंट टूल? सो COPD ने 2009 के बाद से अपनी जो सिंपल स्पायरोमीट्रिक बेस्ड सीवियरिटी थी उसको कंबाइन करके विद सिम्टम्स एक्सेसरबेशन के साथ ABCD टूल डेवलप किया था. एंड नाउ मेन फोकस ऑन एक्सेसरबेशन. तो C और D गायब हो गए हैं ट्रीटमेंट में से, इज नाउ A, B and E. So symptoms, exacerbations. More symptomatic, low exacerbation. Low exacerbation means 0 or 1. moderate but no hospitalization. अगर COPD exacerbation की वजह से hospitalization हो रही है तो it's E. Hospitalization नहीं है, once exacerbation more symptomatic, B symptoms कम है, exacerbations नहीं है, A. So treatment के हिसाब से you can use, we'll discuss treatment. So mainly न्यू चेंज किया है कि इन्होंने C और D को हटा के उसको E बना दिया है, और E में अब अगले साल हो सकता है कि F हो जाए, बट अभी so far they have reduced the to it, E के C और D को मिला दिया है. जस्ट ओनली कि अगर एक एक्सेसरबेशन की वजह से एडमिशन भी है तो विल लेबल दिस पेशेंट एज अ E बिकॉज ट्रीटमेंट डिफरेंट हो जाती है. और इसी वजह से as I told you earlier कि different types, different phenotypes described हुए, तो now they define a terminology the treatable traits. जैसे bronchiectasis में treatable traits आ गए, asthma में treatable traits आ गए, तो now first time they introduce COPD में treatable traits के हर patient is a heterogeneous disease and every patient behave differently. It all depends on their phenotypes, their genotypes, as well as environmental factor, host factors, development things. So, फिलहाल गोल्ड ने दो phenotypes, treatable traits define किए. One is exacerbation based and one is symptoms based or a dyspnea based. So, treatable traits एक ही patient में दो या ज़्यादा भी हो सकते हैं, and दो तो इन्होंने डिफाइन किए गोल्ड ने, बट देयर आर लॉट्स ऑफ अदर ट्रीटेबल ट्रेट्स एज वेल एज इन COPD लाइक पल्मोनरी, एक्स्ट्रा पल्मोनरी. सो वी शुड नॉट जस्ट फोकस दीज टू. बताने का मकसद ये है कि इंडिविजुअलाइज करें अपने पेशेंट्स को एंड टू देयर फिनोटाइपिक जेनोटाइपिक कैरेक्टरिस्टिक्स एंड उसके हिसाब से ट्रीट करें. इफ वन इज हैविंग अ COPD विद ब्रोंकिक्टेसिस, डेफिनेटली द ट्रीटमेंट विल डिफर. लाइकवाइज सिंपल तो COPD में कि आप इओसिनोफिलिक काउंट के साथ ट्रीटमेंट इनहेल कॉर्टिकोस्टेरॉइड्स किसको देनी है, और किसको सिर्फ ब्रोंकोडायलेटर्स यूज़ करने हैं, कौन से पेशेंट को एजिथ्रोमाइसिन मिलनी चाहिए, किसको रोफ्लुमिलास मिलनी चाहिए. सो इट्स ऑल नाउ डिफाइंड सेपरेटली कि आप कैसे फॉलो अप करेंगे उसका. एंड सॉरी एक स्लाइड मिस हो गई मेरी. सो यार ये जो है ना, सॉरी फॉरवर्ड नहीं हो रही, इसके बाद वेरीफाई. सो फॉलो अप के ऊपर सॉरी सिंपली, सो यू स्टार्ट कि ग्रुप ए है यूज़ ब्रोंकोडायलेटर, ग्रुप बी है यूज़ लाबा लामा कॉम्बिनेशन, ग्रुप ई के अंदर स्टार्ट विद अ लाबा लामा कॉम्बिनेशन. पीछे बैक 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 सॉरी ये next. Right. So initial start LABA LAMA combination for group B. Group C में there are usually they benefited with a triple therapy, but you can start with a 2 and define their treatable traits, and then in a follow up देखिए कि इसका मेन प्रॉब्लम क्या है. एक्सेसरबेशन है, थिंक ऑफ एडिंग इनहेल कॉर्टिकोस्टेरॉइड्स, उससे कंट्रोल नहीं होता. मोर क्रॉनिक ब्रोंकाइटिस वेरिएंट है, मोर एक्सेसरबेशन है, यू कैन गिव रोफ्लुमिलास, PD4 इनहिबिटर्स. एक्स स्मोकर है, प्रीडोमिनेटली एम्फाइसीमा है, recurrent exacerbation है, even with a triple therapy you can add azithromycin these patient for a 1 year azithromycin or a macrolide therapy that will reduce the exacerbations in these patients. You can use mucolytics in this group of a patient. सिर्फ अगर dyspnea है so bronchodilator से ठीक नहीं हो रहा, think of alternative diagnoses. Comorbidities are very very common in these patients. Heart failure तो नहीं है, obesity, hypoventilation तो नहीं है. So means individualize, categorize your patients. So nowadays the more focus on a triple therapy, LABA, LAMA, ICS combination. So few quick overview of जो literature last published है in a couple of year में कि क्या literature कहता है. तो main जो trials published में वो Tribute, Trinity, Impact and Ethios. First time है कि किसी pharmacological trials ने मोर्टालिटी बेनिफिट शो किया है. सो दैट्स वाई ट्रिपल थेरेपी पे इतना ज़्यादा हुआ है, क्योंकि बिफोर 2021 किसी भी फार्माकोलॉजिकल इंटरवेंशन की मोर्टालिटी बेनिफिट नहीं था. So mainly these are the two trials, IMPACT and ETHIOS, that shows a mortality benefit. IMPACT is more than 10,000 patient, ETHIOS is more than 8,500 patient. ETHIOS में उन्होंने 2 dosages of budesonide use की थी. IMPACT is on beclomethasone, and they compare triple therapy with either inhaled corticosteroid or LABA or a LABA-LAMA combination. Those shows a significant reduction in exacerbation as well as in mortality. Both trials shows a mortality benefit. So first slide was a reduction in exacerbation. You can see in 2 trials, as well as these trials shows a significant difference in mortality as well. So 1 year all-cause mortality दोनों में थी. So that's why everywhere now it's mentioned that triple therapy can reduce the death rate in these patients. The first trial published that was Tribute, and that shows that triple therapy reduces the exacerbation, but this trial fails to show the mortality benefit. And but Tribute ne first time prove that triple therapy also reduces the rate of decline in FEV1 and improve the quality of life by St. George questionnaire. And this is the real world evidence. TRICOP ज़्यादातर तो pharma based trials होते हैं. This is the real world trial that was done on gold B and D with a triple therapy, and they show a significant reduction in not only symptoms. First chart is of a symptoms, and second one is exacerbation. So significant decline in exacerbation rate and significant improvement in a symptom in a moderate to severe COPD cases जो group B और D के थे with triple therapy. कब ऐड करना है इनहेल कॉर्टिकोस्टेरॉइड, ये बहुत पुरानी स्लाइड है, बट is established कि more than one exacerbation need hospitalization, eosinophilic count more than 300. This is a patient, उसमें absolute indication है you should give steroids. Eosinophilic count between 100-300, you should give, but with caution. Less than 100, more associated with pneumonia. So एक दफ़ा कम से कम उसका total eosinophil count check कर ले. Less than 2% अगर eosinophil count है ना patient का, तो these patient हैं जिनको सबसे ज़्यादा pneumonia होता है. तो ये patient में बहुत ज़्यादा आपके red flags होने चाहिए, इसको हम inhaled corticosteroid दे या ना दे. तो 2% is a cut off जो literature में. Biological agents, ये 4 large phase 3 studies हुई हैं, and जो mainly anti-IL-5 meplizumab, anti-IL-5 receptor antagonist benralizumab पे हुई हैं. 15 to 20% reduction हुई है in exacerbation rate में, but no improvement on FEV1 or a quality of life. So still it's not established treatment, but the trials are going on. तो biological agents क्योंकि asthma में बहुत use हो रहे हैं, so that's why I included this as well. What's the role of biological? What is the evidence that support के reduction किस चीज़ से होती है mortality में? तो first time pharmacotherapy आई है कि triple regime से इन 2 IMPACT and ETHIOS proof कि mortality benefit है. Smoking cessation and pulmonary rehab, we know कि has some benefit on smoking cessation. Definitely सबसे strong mortality है. Long term oxygen therapy, 80s से established है, it reduces the mortality. Not trial and MMRC trials, 2 trials से जिन्होंने proof किया है. Lung volume reduction surgery सिर्फ homogeneous upper lobe emphysematous patient में a little benefit on mortality as far as the mortality is concerned. बाकी किसी का mortality benefit नहीं है. So these are, पहले हम सिर्फ smoking cessation and long term oxygen therapy को लेते थे. Now it's a list that is in a selected group of a patient, not in every patient. It reduces the mortality. So this is an algorithm for diagnosis confirm करें, assessment करें क्या severity है, treatable trait देखें उसका, cause देखें, treatment दें, follow up के ऊपर adjust करें according to treatable trait, and review करें कि patient आपका कैसा है. और so last thing is the exacerbation. So exacerbation की definition भी change हो गई है. Non-pharmacological पे डॉक्टर सोहेल अख्तर and डॉक्टर साइमा बात करेंगी. तो रोम डेफिनेशन यूज़ हो रही है नाउ फॉर एक्सेसरबेशन. पहले सिर्फ वर्सनिंग ऑफ सिम्टम हो तो बस COPD एक्सेसरबेशन है. अब उन्होंने कैटेगराइज कर दिया कि लेस देन 14 डेज होने चाहिए वर्सनिंग ऑफ सिम्टम्स विद सम फिजिकल फाइंडिंग जो डिफाइंड है, एज वेल एज सम बायोलॉजिकल मार्कर्स लाइक CRP यूज़ हुआ है, एंड ABGs बेस, तो उसकी बेसिस के ऊपर माइल्ड, मॉडरेट एंड सीवियर है। आसानी के लिए याद रखें, हाइपर कैपनिया हो गया, सीवियर एक्सेसरबेशन है, ठीक है। और अगर CRP मोर देन 10 है तो मॉडरेट, अलॉन्ग विद टेकिकार्डिया एंड टेकेपनिया। सो देयर आर सर्टेन क्लूज कि अब ये ऑब्जेक्टिविटी है फॉर एक्सेसरबेशन को कैरेक्टराइज करने में। ये रोम डेफिनेशन एंड रोम क्राइटेरियाज यूज़ हुए हैं, कि रोम में ही हुई थी फैसला 2021 में। सो दिस ऑल अबाउट द एडवांसमेंट इन COPD फार्माकोलॉजिकल।